Good morning, everyone. My name is Laura. I'm a Darrawal woman from the Laparoos Aboriginal community of Botany Bay. It's my pleasure to be here to welcome you all to the 2020 NDARC Annual Research Symposium. I'd like to say a special welcome to our overseas guests. Welcome to country is a modern interpretation of seeking and receiving permission to visit areas beyond our traditional lands. It is a ceremony recognising the cultural and spiritual connection to country. It allows us to pay respect to our elders, past and present, and reaffirm an ongoing relationship to the land. It also allows us to reflect on our history and build a vision for a prosperous and reconciled future. Aboriginal people have cared for the land and waters throughout our country in a sustainable framework for the purpose of food and water and resources, and have a close connection to our environment. On behalf of the Laparoos Local Aboriginal Land Council, my ancestors and people, I welcome you all here today and hope you have a great day and enjoy your symposium. Thank you and welcome.
Thank you very much for that welcome to country, and I'd also like to extend my welcome to everybody to today's second instalment in the revamped 2020 version of NDARC's annual symposium. So as you're aware, we're doing a series of 4 events this year rather than our usual face-to-face one. So I'd like to welcome everybody to this second one. And today we're going to be talking about research partnerships and focusing on the work that NDARC's doing and building around really trying to engage with service providers and communities. And I think it's a really important area of work that we're taking on, and we're really trying to, not just think about how we use the findings of the research that we do, but really how do we engage with communities and services and families right from the start. So how do we get them to identify, what the issues and the problems are, and then how do we kind of bring our research skills and expertise in order to help them identify solutions and understand problems in a kind of research and data-driven way. So I could talk all day about this, but no one's here to listen to me, so I'll keep moving. We've got a fabulous program this afternoon for you. We've got people who are actively based in and running, services, clinical services. So it'll be terrific to hear from them. We've got people who are, researchers that are working in that sort of translational space. And we've also got some people who are in both, who've got a foot in both camps. So I think it'll be a terrific program. So to get going, I wanted to ask everyone if today, is something that we're trying to promote in a more meaningful way. If we get everybody to use the chat function to list the Aboriginal lands on which they're listening to this or participating in this session this afternoon, that'd be terrific. I'm presenting from the lands of the Bidjigal people, and I've got to say it's a great honour to be living and working on lands that have been looked after for 10,000 of years by the Australia's First Nations peoples. So if everybody could take the time to put that into the chat function, that'd be terrific. Thanks. Okay, so the program this afternoon is we've got 3 presentations to start with, and then we'll have a short Q&A, so people can ask questions of the 3 presenters. Then we'll look at some featured posters that Jacob's going to run for us. Then we've got another 3 presenters and an opportunity after those final 3 presenters for more Q&A at that point. So again, if people could put the Q&A, if you've got questions as we're going along, feel free to raise them at any time. And if you could put them in the Q&A function, don't use the chat function for questions, put them in the Q&A function. The posters, you'll be able to view them online yourself. So if you go to NDARC's website and look at the annual symposium links, you'll be able to see the posters there. And finally, if I could encourage you, so there's two, as I mentioned, two more sessions after this one over the following next two Thursdays at 9 a.m. So if you haven't registered for those already, please do so. Okay, I'll stop talking and we'll get into the real reason that everyone's here this afternoon. So our first presenter this afternoon is Michelle, Dr. Michelle Fitz. Michelle, can I get you to put on your camera and microphone, please? Terrific, thank you. So Michelle's a Senior Research Fellow at the Menzies School of Health Research in Alice Springs and an Adjunct Research Fellow at James Cook University. I've been aware of Michelle's work for a long time. You know, she's done an enormous amount of work around alcohol and injury and trauma, particularly, you know, in some very remote communities that are, you know, it's hard to it takes time to get there. It takes a lot of time to work with those communities to understand what their needs are and then to think about how to shape her research around their needs. So, you know, she's had an incredible career and she's going to be talking to us this afternoon about some work that she's done with Professor Alan Clough on alcohol management plans. So over to you, Michelle.
Thanks so much for the introduction, Anthony. I'll just bring up my screen now. Okay, go. So as Anthony was saying, my presentation this afternoon is going to be focused on the alcohol management plans in Queensland, and the presentation has a particular focus on reporting on some of the qualitative findings with the interviews that we did with service providers, stakeholders and community residents. I'd firstly like to acknowledge the traditional owners on the land on which I'm based today in Alice Springs, the Aranda people and their elders past, present and emerging. I'd also like to acknowledge the chief investigators, the core team that assisted with the field work, and finally the community councils, the community members, service providers and community organisations for their time and support during the life of the project. So the alcohol management plans and alcohol restrictions that are currently in place in Queensland are not the first type of restrictions to be in place in remote Aboriginal and Torres Strait Islander communities. They actually have quite a long history in Queensland. And the first piece of legislation restricting alcohol supply to Aboriginal and Torres Strait Islander people was the Protection Act. And that was in place continued in through to the 1960s and was in place until the 1980s. In the 1960s, there was the referendum which saw changes to the Constitution, and in all jurisdictions except for Queensland, there were changes to supply and control of alcohol to Aboriginal and Torres Strait Islander people. Then in the 1970s, there was the Community Services Act, and this was where the creation of government-controlled alcohol outlets or canteens came about. And as part of that, these canteens were managed by government and also Aboriginal Shire councils. There still remained restrictions at that time. Towards the 1980s, there was federal pressure from the federal government to loosen restrictions, and from there community councils were tasked with managing alcohol supply in communities and also the revenue that came from alcohol sales. So the revenue that came from these canteens actually was the primary funding for community services, essential services, projects and infrastructure. So community councils were in quite a tricky position. And during that time that they were managing both, there was high rates of alcohol-related harm and injuries. In the early 2000s, in response to the high rates of alcohol-related harm, the Queensland government created the Cape York Justice Study, and that was led by Justice Tony Fitzgerald, and he and his team developed a policy called the Meeting Challenges, Making Choices. And you can see there were three main strategies as part of that policy. So restricting alcohol availability, demand reduction strategies, and then also removing canteen management from councils. So this figure comes from one of the team's publications, and I think it demonstrates the two phases of the AMPs quite well. So following the MCMC policy, the communities had a carriage limit imposed, and you can see there that started at the end of 2002 with Arakoon. There was then a review period by the government in 2005 to 2007. And following that review period, there was a second wave of restrictions which saw the most community canteens close. In 2012, the then Premier of Queensland, Campbell Newman, announced that the AMPs would be under review, and they were under review for 7 years up until 2019. So this is a typical example of a carriage limit in communities that have a carriage limit. So you can see there that community members are able to bring in either light or mid-strength beer or unfortified wine, but typically people weren't able to bring in cask wine, full-strength beer and pre-mixed spirits. So for the qualitative component of the AMP project, the aim was to understand and explore the impact of the AMPs and its perceived impacts on alcohol supply and consumption and other indicators such as violence, injury and community health and wellbeing. And for those who aren't familiar with the remote AMP affected communities, there's a map there on the right-hand side of the screen which shows communities that have total prohibition and those that have a carriage limit. And you can see there that most are based in Cape York and the regional and remote townships that are closest to the McCanns, Weeper and Mount Isa. So during the project, we spoke to over 380 people that included community members, community leaders, and also representatives from government and community organisations. The reason why we spoke to so many people was because we wanted to be able to give each community that we were working with a report back. We also did surveys with 1,200 community members as well. And there were some of the communities were asking for this project to happen. So we wanted to make sure that we were able to give meaningful information back to each community. We attempted to speak to people that had long-term experience in these communities, particularly pre and post 2008, so the second wave of the restrictions which saw the canteens close. And as you can see there, there's a list of different service sectors that we spoke to. So just in order of frequency of mention, you can see there overwhelmingly illegal drinking or sly grog was spoken most about. There was also migration from affected communities, criminalisation, illicit drugs, changed drinking behaviours and discrimination were mostly talked about. But for the purposes of the presentation today, I'm just going to be talking about the first three. So as I said, overwhelmingly people spoke about illegal drinking. So that included homebrew in a small number of communities, but also people bringing in alcohol for their own personal use. But overwhelmingly people talked about the impact of the sly grog trade. So when people were talking about the positive impacts of the AMPs, they said that initially, particularly with the second wave, they had noticed a decline in injury and harm, particularly to women and children, and other positive changes such as increase to school attendance. But a lot of that had been undermined by the sly grog trade. You can see there in the first quote that a bottle of rum that would sell for $50 was people were paying 4 to 6 times that amount. And in the second quote there, you can also see that in times when it's wet season, it's difficult to leave the community, that people were paying up to almost $1,000 for a bottle of rum. The sly grog trade, the profiteers or the people that are participating in the trade had quite sophisticated ways of being able to avoid police apprehension, including hiding alcohol in bushlands, and also making hoax phone calls to police, including attempted suicides, a car rollover. So police would attend to those call outs, and with the limited resources would be out of the community, for example, and then through phone calls and other communication, a car with alcohol would be able to come into the community. This quote comes from a police officer working in a remote community where there was total alcohol prohibition. I know it's quite a long quote, but I wanted to include it because I think it demonstrates the type of risks that community members who are trying to get access to alcohol are taking, and then also the experiences that police have in enforcing these restrictions. And so you can see there by this quote that it was a police road stop that was happening in the evening, and people were taking a significant risk, including turning headlights off, speeding on unsealed roads, and almost the car rolling. Another impact that people talked about was migration from A&P communities. So some people talked about permanently shifting from a remote community to a township such as Weipa or Cairns to get access to alcohol. And other people talked about people leaving remote communities to go to Weipa and Cairns and to Mount Isa as well for short periods of time to get greater access to alcohol. And that led to issues for those townships, including violence in town camps, drink driving, and overcrowding in homes as well. And then finally, criminalisation. So in some of the communities, it's not well known that a large portion of adults have a breach of the AMPs as part of the Liquor Act. And so you can see there in the first quote that people that didn't have a criminal history prior now have a criminal conviction. And a lot of people talked about having thousands and thousands of dollars of fines related to breaching the AMPs. It also had consequences for people's work, and also for the financial resources in households as well. So I guess where I wanted to finish the presentation was talking about if the early achievements, I guess the unintended consequences can be addressed before the achievements become eroded. So what we and others have said about the AMP policy is that it's been very much left to drift. There's been limited investment in the policy itself, and there's been a lack of action on the long-standing issues, including criminalisation and the sly grog trade as well. And as I mentioned before, that the AMPs were reviewed for 7 years, and as part of this project, we're providing the Queensland Government with updates from this project as well. But it's unclear what changes or what has come from that review. What will that mean for the AMPs? What we found was that there was really heavy reliance on supply control, which has unravelled with the sly grog trade, and there was actually other pillars that weren't invested in, such as greater drug and alcohol services, which as part of our interviews and surveys, community members were asking for. We're also suggesting that communities should be more empowered in the conversation. So this review that we had done was several years after the AMPs had been implemented. As part of going forward, we suggest that community members should have greater access to figures looking at trends and rates of particular indicators if they're going to be responding to local issues. And that's, I guess, where, speaking of what Anthony mentioned before about the theme of this, the presentations today, this is maybe where researchers may have a role if communities are interested in having researchers involved in this process. We also suggested that it shouldn't be a one-size-fits-all policy. So there were some communities that were wanting to have alcohol in a well-regulated environment as an opportunity to have teach people about social drinking and having a drink with a meal. Not all communities wanted that type of permit. And then just finally, more robust approaches to controlling alcohol availability. So the other thing that we found was that the sly grog, those convicted of a sly grog offence were receiving similar penalties to those that were bringing in alcohol for their own personal use. And we also found that another way that people were able to overcome the restrictions, particularly in Weipa and neighbouring communities, was around ordering alcohol from Dan Murphy's, which was then sent to Weipa. And that so if there's any if there's more robust approaches to controlling alcohol, it does need to include representatives from the liquor industry in that conversation. These are just some references from the project. If you do have any questions about the project, please feel free to get in touch with Ellen or myself. And thanks so much for your time.
Thank you, Michelle. Great, thanks, Michelle. That was, as usual, a terrific presentation. And we'll keep moving on to George Economides, who's next. So George, if I could get you to put your camera and microphone on. So George is a PhD student here at NDARC. His project is looking at working with the New South Wales government on reducing rates of out-of-home care, children being placed in out-of-home care. So, you know, I can't stress enough what a huge project this is, and, you know, what a challenge it's been for anyone, let alone a PhD student. So George has done a terrific job. This is a, you know, multi-million-dollar programs that have been rolled out across New South Wales, and George is taking the lead on evaluating those. It's a little bit early for the main results. So George is going to be talking this afternoon about the quality of evidence for evaluating the two therapeutic programs that the government, New South Wales government's rolling out, one called family functional therapy and one called multi-systemic therapy. So he's done a systematic review to look at the evidence about the quality of how well those programs internationally have been evaluated. So over to you, George.
Thanks, Anthony, for that introduction. Before I begin my presentation, I'd also like to acknowledge the traditional custodians of the land on which we gather. I'm performing this presentation on the lands of the Bidjigal people, and I'd also like to extend my respects to Aboriginal elders past and present. So my review is entitled The Effect of Family-Based Therapies on the Recurrence of Physical Abuse and Neglect Among Children in High-Risk Families, a systematic review of experimental and quasi-experimental studies. And I'd like to give thanks to my collaborators who I've worked with on this review to date, who are listed on screen. So what does the scale of the child maltreatment problem look like in Australia and the international context? So the image presented here shows the number of children aged 0 to 5 years who've come into contact with Child Protective Services in New South Wales. So right off the bat, you can see that about 14% of all the children surveyed, so of the 153,670, 14% of those children have had some level of contact with the Child Protective System, in that they have been screened and reported as having a risk of significant harm that meets the threshold of Child Protective Services. So rates such as that are comparable to childhood asthma. And about 4%, or you can think of it as 1 in 30 children aged 0 to 5 years in New South Wales, have had their abuse substantiated or verified by Child Protective Services. So you can think of that as 1 in every 30 children, or 1 child in every classroom having their abuse verified, in this case by the Department of Communities and Justice, or DCJ for short. So what has the child protection policy, practice and response been on an international level? So traditionally, home support and visitation services have been used. So that involves things like nurses going to family homes to help parents feed, clothe, provide appropriate shelter to their children, and refer families onto relevant services where appropriate. Case management services, so undercutting the socioeconomic factors that will globally assist with parenting, so legal issues, housing issues, vocational educational needs. Parenting programs, so therapists and social workers running workshops that parents attend either by themselves or with their children. and then family-based therapies, which is the focus of this review. So in New South Wales in 2015, an independent review in out-of-home care was commissioned called the Tune Review. And it found that although child protective services were adequate in responding to crises, there was little done, or there was an opportunity to really work on those early services in terms of preventing maltreatment from manifesting in the first place. And one of the key focuses that arose from that review was an investment in family-based therapies as part of the family prevention and restoration approach under both Their Futures Matter, which was an initiative that commissioned the two projects that Anthony was referring to before, family functional therapy and multi-systemic therapy for child abuse. So with that, that was our focus, family-based therapies. So the research question in this review specifically is, do family-based therapies reduce the recurrence of physical abuse and neglect among children with one or more prior substantiated incidents of physical abuse and neglect compared with the usual standard of care, so business as usual essentially. Our inclusion criteria for the systematic review were we were interested in randomized control trials and quasi-experimental studies. Our intervention inclusion criteria was that the child was aged 0 to 17 years, that there was a substantiated incident of physical abuse or neglect, and that the child was at ongoing high risk of abuse and neglect. And our intervention characteristics for how we conceptualized a family therapy were that the parent and child had to participate in therapy, but there was also scope to allow for family members beyond the traditional nucleus, so aunties and uncles, grandparents, and that the parent and child had to attend at least one therapy session together. And that the therapy was delivered within a psychological framework. So that was often by a qualified allied health professional like a psychologist, psychiatrist, counsellor, social worker. And the study outcomes of interest were those that were available revolved around recurrent abuse and neglect. So the PRISMA flowchart was in accordance with Cochrane guidelines. So we reviewed articles from 3 primary databases, CINAHL, Scopus and PsycInfo, as well as a number of grey literature sources, so forwards and backwards searches. We typically screen through the traditional title, abstract and full text process, but of interest is the last text box, which showed that ultimately 13 studies were selected for review, 11 RCTs and 2 quasi-experimental studies. So the 3 outcomes that were indicators of recurrent abuse or neglect that were available and that we investigated were child abuse and neglect re-notification rates, which I'll explain by example in a few slides' time, child out-of-home care entry rates, and other measures of recurrent child abuse and neglect, like the child abuse potential inventory or the parent-child conflict tactic scale. So the screen here presents the risk of bias assessments that were individually completed for all 13 studies, but I presented the 11 RCTs here. Green cells indicate a low risk of abuse, yellow cells indicate a moderate risk of abuse, and red cells indicate a high risk of abuse, of which there are clearly none. So I guess the takeaway message from this straight off the bat is that at least in all studies, there was at least a moderate overall level of abuse, overall level of bias, if you look at the right-hand column. And some of the issues that were commonly found in terms of bias across these studies was that, there were potential issues associated with confounding at randomization, in that, some studies might not have accounted for confounding, they might not have reported on it, they were underpowered to detect any sort of difference because of their small sample size. They didn't report on any interventions. Because family therapy is different from pharmacological studies from which these risk of bias forms originated, it was sort of impossible in all studies for the therapist and the family to not know what intervention they were receiving. There was also missing outcome data across many studies, and across all the studies, none of the authors pre-specified an analysis plan, so we weren't sure whether their results were actually a priori specified. So the image here shows the risk difference, so the absolute risk difference between the intervention or the family therapy and usual care across the studies that actually measured this. So we've got 4 studies. Anything right of the 0%, so anything right on the right-hand side of the vertical red line, indicates that usual care or the comparison group had lower rates or the children who received usual care had lower rates of abuse at the end of intervention. So we see that there's only one study, so AFCBT by Kolko in 2018. And the other studies on the left-hand side of 0% suggest that the intervention condition, or families who received the intervention condition, had lower rates of child maltreatment at the end of therapy. It's important to note that this is a crude risk difference of absolute risk. We weren't able to measure, for example, adjusted main effects because a lot of the studies were methodologically poor in the sense that they didn't report certain numerators and denominators, so we couldn't exactly examine confidence intervals. So these are just unadjusted absolute risk differences in child maltreatment rates. So in summary, the best estimates of a causal effect were crude risk differences. So a lot of the studies reported within group differences. Obviously between group differences would be a more accurate examination of causal risk. Several family-based therapies may reduce notifications, but one program, the Kolko study on the right-hand side of the 0%, had a small to nil favor of usual care. Residual confounding likely existed because randomization was not achieved or balanced between groups, so they weren't necessarily exchangeable, and they might have differed on a number of baseline characteristics that weren't adjusted for at baseline. And a number of methodological concerns also may have been in effect, such as confounding, no main causal effect being estimated, so like I said, within group comparisons or interaction terms rather than focusing on main effects. And there was also a selection bias related to follow-up, loss to follow-up. So in a lot of these studies, they only reported outcomes for families that completed the program in full, meaning that the outcomes of families who withdrew early weren't excluded. So naturally, there's a selection bias towards favouring families who completed the intervention in full. In conclusion, there may be beneficial effects of some family-based therapies on recurrent child abuse and neglect, but we can't conclude this from existing studies. And to understand what works to prevent child maltreatment, greater scientific rigour is needed in future evaluations. Thank you.
Terrific, thank you, George. It was a great presentation. Now we'll keep moving to Sky Trudgett. Sky, if you could just get your camera and microphone on. While Sky's doing that, I'll quickly introduce her. So Sky is also a PhD student here at NDARC, and she's been doing her research working with partnering with NGO-delivered programs for really high-risk children. And one of the key things that we discovered early on in doing that work is that we're trying to get better at helping the services collect and utilise their data, to help the clients that they're working with. But one of the things that raises is how we really sort of think about and meaningfully engage with the idea of Indigenous data sovereignty. So Sky agreed or was keen to take on some work around that. So she's going to present some work that she's done, again, on a literature review to sort of understand what we know about Indigenous data sovereignty and how it might be operationalised into practice. Just before we start, can I just remind, after this will be a Q&A session after Sky's presentation. So the next few minutes will be a great time to start putting in your questions if you'd like to ask one. Okay, over to you, Sky.
Thanks, Anthony. I just wanted to start also by acknowledging the traditional owners on the land on which I'm at today, which is the Awabakal people. I also wanted to acknowledge that this is NAIDOC week with the theme of always was and always will be, which I think is really important and central to the concept of Indigenous data sovereignty. Also flagging that this is a repeat of the presentation that I'd done on Tuesday, but with a little bit more time to actually talk about what was found and about this project. So apologies for those who feel like they're having deja vu, but I am really keen to get into this a little bit more than what we had the chance to on Tuesday. So as Anthony had mentioned, the project that we're working on is an ARC funded project. It's titled YARN, and this is the Youth Research Network. So the concept is understanding how we can improve social, economic and health outcomes for high-risk young people in remote communities through the adaptation and implementation of transdisciplinary research approaches. So what that means in practice is we're working with a lot of communities and community organisations who are working with high-risk young people, but they're really struggling to implement any kind of routine data collection. A lot of it is anecdotal, or it's really ad hoc. There's no systematic approach to this at all. And so being able to tell the story of what's changing for young people who are in the program, or that, you know, advocate for additional funding or additional supports, is kind of like not really available to these services. So what we wanted to do was support them to implement a model of care that was really consistent across many sites in the country, and also implement a routine assessment tool and reassessment tool, so they were gathering the same data at routine times, and they could really get a good solid evidence base for themselves, and then also for the Yarn network. So that's the purpose of the project. And so you can see up the top here, I don't know if you can see my cursor, but the visual that is up the top is one that was drawn whilst we were in one of our research projects by a lady by the name of Mamie Butler. She's a director with MPY Women's Council in South Australia. And what this image shows is how the network operates. The network sees Aboriginal and non-Aboriginal people coming together around issues that need to be supported for young people. And so there's many communities that participate, and the communities are on the outside here. So you've got researchers, community services, and local people at the centre here. And these are the topics that we're discussing. And so these people come back and feed out to all the communities on the outside. And this is their knowledge that goes in between. Sorry. So this is a network. And when we came together, what we understood was that young people really need to be considered in this space around when they provide their data, what happens to it then? What does that mean? What's the story that's told with it if we're able to do the work that we set out to do? And unfortunately, the majority of these young people are Aboriginal and Torres Strait Islander kids, even though these programs aren't necessarily delivered by Indigenous organisations. So this is what brought us to the point of considering, well, how do we implement Indigenous data sovereignty in this research project? But then how do we do that at scale for all of these programs? And so we spoke a little bit about the project before, but what we, so what does this mean is where I was getting to, sorry. And so we decided that the best way to understand what this means and what we need to do was to go through the process of a literature review. And so we have spent quite some time doing a literature review and then also updating it so it's really current. Indigenous data sovereignty is a really emergent topic in this country, and it's being led by some great people who are doing wonderful work, which means that we're constantly learning new things. So we've been updating the literature review as we go, and we're at over 7,000 papers that have been reviewed, and we've been reviewing these to understand, well, what of these papers is about Indigenous data sovereignty, or what are these about is about research kind of methods, and what is about Aboriginal people in general. Because it's so emergent, there's a lot of things and topics around Indigenous data sovereignty that have been implicit in the previous papers that we've been exploring. So this is another kind of thing that we've been tackling. So what we found was that knowing that we had that as Aboriginal and Torres Strait Islander people, we have minimal control over our data. We wanted to understand the principles that are in place through the literature, and we wanted to implement that into this Yarn research project. And what we've come up with so far is that there's 8 principles that have emerged from this literature review. And those 8 principles are ownership, control, access, custodianship, accountable to First Nations, amplifying the voice of community, relevant and reciprocal, and sustainably self-determining. So I'm just going to take a moment to go back through these again and explain them, and talk to you a little bit about how we've operationalized that within this research project, or how we've seen some of the NGOs that we've been working with operationalize these principles. So ownership is around who owns the data, whose is it, even though it might be contributed in different ways or sits with different people, who actually owns it. And so with this, what we've done is that all the data that we collect is actually delivered to us by the services. So we don't hold the central we don't hold a collection. We do have de-identified data, which we say, and it has been agreed to in our ethics application, that the ownership of this data actually exists for Aboriginal and Torres Strait Islander people. So they own the narrative, they own the data, they own what is about it, and this is the young people who are contributing it at the end of the day. The control, so is who says what happens with what. So the control of the data sits with the services. So the services have implemented routine data collection systems and databases, and they control when the data comes to us and how it comes to us. And we work with that de-identified data set once it's handed over. Access, so again, this is the same kind of thing. So young people within the services have access to their own data. The data sits with the services, and then the services don't provide us access to the data, they provide us an output of the data. Again, the custodianship is who owns it, who holds it, where does it sit? And so this is why we've implemented this approach of the services have the database and we get an output. That means that for Aboriginal and Torres Strait Islander services, that data is held by Aboriginal people. And I think that there's still some movement that needs to get towards all data relating and pertaining to Aboriginal and Torres Strait Islander people being in the hands of Aboriginal people. The next principle here is accountable to First Nations. So this one is important in that once you get the data and then you tell your story with the data, who determines the narrative? Is that okay, what you're saying? Is it culturally appropriate? Is it does it work within the local context and what's happening on the ground? So the way that we've applied this principle is we have our network that I spoke about previously, and this consists of representatives from each community, and each community is also linked with Aboriginal and Torres Strait Islander supports who have said that we're okay to do this research, and we will check back in with them before we're publishing to make sure that what we're saying is okay. And again, so the next principle is amplifying the voice of community. So this is, are we using research and our findings in our publications to really talk about what's important to community and the narrative that community would like to have told about them. So we're applying this in the same way that we're checking back all the time, making sure that this is approved and supported. Relevant and reciprocal. So I think this one speaks for itself. So like, are we doing research for us and for community? Sorry, when I say us, for Aboriginal people and community, is it relevant? Does it make good sense? Or is research being done for someone else? And so this is one of the core principles that we're really trying to ask, and through our research, what we've been trying to do is check that. So we're checking that first. We went through an entire process of over 12 months of checking that, like, is this relevant? Does it make good sense? Is this something that we need to do? And then reciprocal, in that part of our ARC grant is that we have employed community researchers on the ground in each of these locations. And then finally, sustainably self-determining. So this one is important in that if we're doing research and it gets towards the point of being self-determining and supporting Aboriginal people to have agency, how do we make that not just a point in time thing? How do we make that continue on? And so this research has embedded that principle from not having, I spoke about it before, but not having data collection systems where we as researchers go to community, collect the data and hold it all. We've actually worked with services to embed the data collection approaches, to embed the model of care, and to start thinking about how will they sustain this after the life of the research. So that's just an example of some of the things that we've been doing. And I think I would respond to a couple more things in the Q&A, but that is it for now. Thanks, Anthony.
Right, thank you, Sky. we might not go to the Q&A just now. We might leave that for the end of the session, just in the interest of time. So please keep your questions coming, and we'll get to them at the end of the session today. So our next part of the program this afternoon is the featured posters session. So I'll hand over now to Jacob to run us through that. And just a reminder that you can go onto NDARC's website and vote for your favourite poster, and that you can do that up until the 25th of November. So please don't be shy, go and do that. All right, over to you, Jacob.
So this review is still underway, so I'm just going to briefly present on the background and gaps and where we're headed in terms of a review of supported accommodation for people released from prison. Supported accommodation can take different forms, ranging from group homes or halfway houses to scattered site housing programs, with support ranging from residential support services, case management, or therapeutic home visits or group programs. These services, which address the complex and reinforcing challenges faced by people released from prison, may play a role in improving the post-release outcomes for this group. Despite this, we have limited high-quality evidence to support service providers and policymakers to form evidence-based decisions to develop and evaluate programs and their effectiveness. To determine the current best evidence practice, I'm conducting a systematic review to identify literature describing supported accommodation services. This review will importantly critique the methodological quality of evaluations and describe the characteristics of these programs and their effectiveness. As I mentioned, this review is still underway and we're partway through full text screening. So far, it appears that the existing literature is lacking rigorous evaluations of supported accommodation with limited descriptions of program components and theoretical frameworks, and there is considerable variation in how programs operate and are evaluated. On initial review, it appears that the majority of the literature is coming out of the US and the UK. That's not surprising, as the vast majority of incarcerated people globally are in the US. There is a definite need for improved literature related to other contexts. Due to the difficulty identifying literature relevant to this review, I so far really strongly recommend publication of evaluation studies of supported accommodation services. These kinds of services really rely on evidence not only to inform their programs, but to support applications for future funding and expansion. To help achieve this review will be completed, and I will conduct workshops with service providers and interviews with service users to develop a program framework for supported accommodation incorporating the existing evidence with expertise of lived experience and service provision.
Good afternoon. Today I'll be talking about my poster, Trajectories of Parental and Peer Supply of Alcohol Across Adolescence. So parents are one of the main suppliers of alcohol to adolescents, often doing so with the intention of safely introducing them to drinking. However, there's a growing body of evidence indicating that parental supply of alcohol is associated with increased alcohol consumption and alcohol-related harms. Existing studies tend to treat parental supply as a simple exposure, so either yes or no, and they also ignore supply from other sources such as peers. In this study, we explored whether there are distinct patterns of supply from parents and peers that occur during adolescence. We used data from the Australian Parental Supply of Alcohol longitudinal study covering ages 13 to 18. We identified 5 distinct trajectories or patterns of parent and peer supply. Briefly, Group 1 received no or limited supply under 18 years of age. Groups 2 and 3 were similar, both being supplied full serves of alcohol from mid-adolescence from parents and peers, but Group 3 also received sips from parents in early adolescence. Group 4 were supplied sips from parents from early to mid-adolescence, with supply of full serves happening later in adolescence. Group 5 were supplied full serves of alcohol from their peers in early adolescence, with parental supply increasing from mid-adolescence. We found that being female, being older, having substance-using peers and lower parental monitoring in Year 7 were predictors of being in those groups with earlier onset supply of full serves. So these results show that parental supply of alcohol is not a homogeneous practice. It does not occur in isolation from supply from other sources such as peers. The next steps will be to examine whether there are particular trajectories that pose a greater risk for young people as they enter adulthood. Thank you, and have a look at my poster for more details.
Hi everyone. This systematic review will critically appraise the academic literature from the last decade around strategies employed to reduce alcohol and other drug-related harms in licensed entertainment settings and outdoor music festivals. The use of alcohol and other drugs and their associated harms in these settings is an ongoing public health concern. This has been the focus of several major inquests recently, including the Joint Select Committee on Sydney's Nighttime Economy, the Coronial Inquest into the death of 6 patrons at New South Wales music festivals, and the Special Commission of Inquiry into the drug ICE. Given the importance of addressing these harms, this review aims to examine how different interventions may impact health, social, and criminal justice outcomes. Examples of strategies include venue and staff interventions, policing tactics, peer education, chill spaces, drug checking, community interventions, medical services, and health alerts. This review is systematic and will follow the PRISMA protocol. 12 electronic databases were searched. All studies had to be published in English between January 2010 and December 2019. Types of studies eligible for this review include both experimental and observational studies. The review has been registered with Prospero. Examples of outcomes to be tabulated in the synthesis of studies include emergency medical treatment presentations, unconsciousness and unintentional injury or death, police recorded instances of offenses by type, unsafe and unwanted sex, and driving under the influence. A narrative synthesis of the data will be conducted that involves exploring relationships between studies. This study will contribute to research and policy by reviewing studies between 2010 and 2019 on alcohol and other drug harm reduction interventions in licensed entertainment settings and outdoor music festivals, examining for similarities in design, implementation, and outcomes in reviewed studies, and identifying implications for policy and practice in these high-use settings. Thanks.
Hi, my name is Wingsi Ewan and I'm a PhD student at NDARC. I'll be giving a brief overview of a study that examines patterns of transitioning across physiological and psychosocial alcohol-related harms in adolescents. Alcohol-related harms cover a wide variety of negative consequences that can be classified into different dimensions. The physiological dimension, which includes experiences such as hangovers or vomiting, and the psychosocial dimension, which includes experiences such as getting into a fight or having your personal relationships being impacted by drinking. We used data from a cohort of 1,828 young Australians to examine whether a wide variety of adolescent, parent, and peer factors at age 13 were associated with patterns of transitioning across physiological and psychosocial alcohol-related harms between ages 15, 17, and 19, and whether these patterns of harm were then associated with self-reported symptoms of alcohol use disorder at age 20. We found 5 main patterns of alcohol-related harms experienced, as shown here. So, for example, participants in the late escalation to physiological harms pattern did not experience any harms until age 19, where they then reported experiencing at least one physiological harm, such as having a blackout. And participants who experienced the gradual escalation to all harms pattern escalated from no harms to physiological harms to all harms, which includes psychosocial harms such as having a fight while drunk. Some of our findings that parents and caregivers of adolescents should take note of is that adolescents who are female and adolescents with more substance using peers at age 13 were at greater risk of experiencing early physiological harms. And importantly, the combined experience of physiological and psychosocial harms in late adolescence predicted meeting DSM-5 criteria for alcohol use disorder at age 20. However, this is not a formal diagnosis, but rather an indicator of potential clinical problems related to alcohol use. Thanks very much for your time, and for more information, please check out my poster or contact me using these details.
Terrific. So thanks to all 4 presenters there. And as being said, if you go onto NDARC's website and you've got the opportunity to vote, view the posters and vote for your favourite one. Thanks very much. Right, we'll keep going. We've now got another 3 presenters, and then we'll have some time for Q&A at the end. So our next presenter is Dr. Michael Doyle. Michael, if I could just get you to get your camera and microphone ready to go. I could talk all afternoon about how much I admire Michael and his contribution to research, but I won't, don't worry. So he's a research fellow at the Centre for Research Excellence in Indigenous Health and Alcohol at the University of Sydney. You know, as well as developing his own research career, he spends a lot of time, you know, providing support and mentorship, you know, to some of my Aboriginal PhD students, and also to some through the, to most of them, in fact, through the CRE, but also to, it's not just students, also to me. I've, you know, spent many years relying on Michael and getting his advice, you know, about how to approach issues around Indigenous health and research. So, you know, I'm eternally grateful to him for his patience and willingness to support research across multiple universities. Okay, I'll shut up and hand over to Michael.
Thanks, Anthony. The feeling is mutual. So I'll just start sharing my screen. You should all now see that, I think. Hang on, there's something not quite happening with this. So thanks for inviting me to present today. Today I'm talking a little bit about one particular project which we're doing with Justice Health around the their patient health survey. So it is NAIDOC week this week, so happy NAIDOC week everybody. Always was, always will be Aboriginal land. I'm here at my office in at Sydney Uni, so it's the Gadigal people of the Eora Nation, and I'd like to acknowledge their traditional owners, past, present, and emerging, elders, past, present, and emerging, I should say, as well as all Aboriginal and Torres Strait Islander people online today. So when we're doing work with our with Aboriginal communities, we really should be upfront about what some of the benefits are, and before we even start the process. So in the area of prisons, about 75% or 3/4 of people entering prison report risky or alcohol or other drug use, and that's pretty consistent, not just in Australia, around the world, and for Aboriginal, Torres Strait Islander people and non-Aboriginal Torres Strait Islander people in prison in Australia. This is a high priority within the Aboriginal community. We have high imprisonment rates. I'll talk about that in a moment, but almost no. I'm yet to meet an Aboriginal family that has not been affected in some way by somebody going to prison, or perhaps they've been to prison themselves, and this every family in some way is affected. It was so important that it was mentioned in the Uluru Statement as well. So they did a consultation about recognition in the Constitution, and one of the things that came back was about imprisonment and needing to redress this. We hope through this work that more effective AOD treatment could lead to improved health, and that's the primary thing we're looking at, as this is a health perspective. We would like to also maybe reduce likelihood of return to prison if people are better able to manage their alcohol and drug use disorders. So the imprisonment rate you can see there, so that's from 2009 to 2019 from the ABS, and there's 2 stories on screen there. You've got the ever increasing Aboriginal and Torres Strait Islander imprisonment. There's been a slight decrease from 2018 to 2019. And it'll be interesting to see the rates this year, because there's been an effort to reduce the number of people in prison due to COVID. So it'll, like so many other things, it'll be quite interesting to see what the stats say next year. But the other story there is the non-Indigenous imprisonment rate has remained fairly stable over the same period of time. So this is looking at some data from the Justice Health Forensic Mental Health Network 2015 patient survey. We're in the process of writing a series of 3 papers with Julia Bowman, who's the head of research at Justice Health, and her team, part of that process as well. The survey has 11 1,132 participants, as you can see there, and they ensured that they had a large enough sample, particularly for Aboriginal women, because they were a bit underrepresented in previous iterations of the survey. The survey was previously known as the Inmate Health Survey, but it is sort of more correctly now the Patient Health Survey, as these are patients of the network. The Aboriginal participants were generally younger, and Aboriginal participants were more likely to have spent time in juvenile detention, and they were less likely to have completed formal education, or finished year 10. So this is just looking at the alcohol use as per the Alcohol Use Disorders Identification Test, and you've got no consumption, which is a score of 0, low consumption or is 1 to 7, hazardous, harmful 8 to 19, and high risk dependent is 20 and above. You can see there for Aboriginal men there is a this is a chi-square test, and there is a significant difference in the high risk dependent category. Also, you see as well with Aboriginal women. This is, we followed this with some other work that also looked at the audit category and by different types of drugs and also tobacco use. And what we found was there was cannabis was there was a significant association with people using, drinking more at higher levels, if you like, being more likely to have used cannabis as well. There wasn't a particular pattern of use by any of the other drug uses you can see in there. So we did a multivariate analysis and by audit again, and some of the demographics, and you can see that there's a bivariate analysis you can see on screen there, and there were a couple of things that turned up to be significant within that, and once again the cannabis. So we've done a lot of analysis on a range of things, but we've only included, or I've only included in this the things that were significant. And you can see there when in the multivariate analysis a sort of impact on sort of sex isn't shown through to be significant in the multivariate, but it remains to be significant within the cannabis and also heroin use. Those are, I did a paper at the beginning of the PhD, which Anthony probably remembers, and so some of these findings are quite consistent with that, but this is a much larger data set than the one I used for that. There was about 200 participants in total, and that with 40 of them being Aboriginal, and so we're able to do a lot more analysis and explore a lot more different issues because of the variables in the patient health survey. So we're pretty excited that we'll be putting a couple of papers out, hopefully to be published in the next 12 months or so. Implications for this. So high levels of imprisonment need to be addressed, and that's an ongoing issue. Justice targets were added to close the gap. So these things will be hard to go against the flow and to start reducing imprisonment, particularly if you think of the social determinants of imprisonment are very similar, pretty much the same as the social determinants of health. And if you've worked in that space, you sort of see that it's quite difficult to change those things and turn those things around. But just because something's hard doesn't mean we shouldn't do it. And Australians have done lots of hard things before, and we should be doing this as well. We need to continue to have alcohol and other drug treatment in prison, but alcohol is a particular issue in its own right, and we know that it's the most commonly used psychoactive substance. But in prisons, there tends to be a focus upon the illicit drugs, but we really need to have a think about how we can provide better treatment to people in prison with alcohol, and also post-release support, so that when they return to the community, they're less likely to perhaps return back to the same sort of consumption patterns as before. Cannabis and alcohol programs may be needed. Cannabis has almost been a bit like the elephant in the room, I guess. There's been a focus on some of the illicits, heroin and amphetamine use, or amphetamine type stimulants within this area, and not so much of a focus on alcohol. But I haven't really seen anybody talk too much about the need to do work with cannabis within that. And I think that's possibly because at times cannabis can be perceived as being a bit of a harm reduction in its own. People don't necessarily become too dysfunctional while using cannabis, but we really need to look at what can be done around that. Look, thank you. That's my presentation. I want to also thank Farah Alsari and Kate Conograve, my colleagues here at Sydney Uni, who have been working on this bit of work with me. That's it for me. So thank you. I'll stop
Terrific,
sharing
thank
screen.
you. Yep, great, thanks, Michael. And in typical modest fashion, you're calling it a little bit of work. I think it's much more than that. All right, our next, we'll keep moving. As I say, we'll have time for some Q&A shortly. So our next presenter is Kath Foley. So she's a research fellow here at NDARC, at UNSW. And she's also a clinician and program manager with the Mid-North Coast LHD. Her background is she's a clinical psychologist and done a lot of work in substance abuse and mental health. So when she first came to do some research at NDARC, she was absolutely terrific because she really brought that clinical focus and how do we kind of really focus the research and integrate research into the clinical sphere. So she's been really helpful in helping us think through those sorts of issues. And not just in Australia. Today, she's going to be talking about some work she did on integrated care that's been taken up over in the UK. So I'll hand over to you now, Kath.
Thank you, Anthony. Thank you to NDARC for inviting me to speak and to all of you for coming along to listen. I would also like to begin by acknowledging the traditional custodians of the lands that we are gathered on today, and in particular, I acknowledge the Gambanga people of the Mid-North Coast region where I'm speaking from. So paying my respects to past, present and emerging leaders, and just recognising the work and leadership and guidance that my project, and I'm sure all of the projects today, have benefited from our Aboriginal colleagues. On that previous slide, just also recognising that this is quite a big collaborative piece of work, and those affiliations, there are several groups of people that are involved in this project and have been from the beginning. Don't have a big enough slide to put them all there, but acknowledging all of that work that has come along. I will try and move through this fairly quickly. So this little project started with a group of clinicians who identified a clinical issue. They were losing clients as clients were moving from the mental health service to the drug and alcohol service, and they wanted to do something about it. They also wanted to evaluate what was happening and find out, what works and what doesn't, thinking that other people would want to know about this as well, because the problem of co-occurring disorders with mental health and drug and alcohol is universal, not just in Australia, but also internationally. So the way we approached this was to seek evaluation support from NDARC and from the Centre for Rural and Remote Mental Health and some other experts, and developed a little project on the Mid-North Coast with the North Coast Rehabilitation Service and the Coffs Harbour Drug and Alcohol Service, where the clinicians came together to identify how they could look at this problem and identify a way forward. What we knew was that co-occurring disorders were prevalent and challenging to treat, and that they result in, I guess we could say, less than optimal wellbeing for people and communities. And what we found out fairly quickly through the literature search was that there were two things that appeared to be missing consistently. So a standardised model that people could use that could be translated effectively and feasibly across multiple settings, and more importantly, a practical and feasible process for guiding services through that process of implementing a model and making a change to clinical practice. Two principles underpinning our work were the principle of best evidence practice, combining what we do see in the literature with the views of service providers and consumers. Studies developed in controlled settings or elsewhere aren't always easily transferable to clinical settings, and the views of clinicians and consumers are critical to making that work. We also discovered as we went through this process that higher levels of participation equated to higher levels of ownership and uptake, and that the culture of the setting or the clinic is a powerful factor influencing patient outcomes. So as Sackett has reported, not just about applying evidence into practice, but combining that best available evidence with clinical expertise. So the methodology that we used was participatory action research, something that we could work from the ground up with the clinicians driving the process. So this is a very simplified description of the model that we came up with through that process. So we followed the process of developing the model and also how it was implemented and what was effective and not. So simply 1, 2, 3, 4 steps. The first thing that we start with that idea of fragmented care, disjointed, disempowering, ineffective, and inefficiently responsive to the voice of service providers. We developed a model based on the evidence and that work with clinicians around what actually meant something in their setting and the consumers around what they needed. Step 3 then was about an uptake framework. How do we actually translate that model into a clinical setting and sustain it ongoing? Finally, at the end, we hope at some point coordinated, comprehensive and inclusive care that's driven by collaboration between service users and service providers. So if you look at that model, one of the key components there is no wrong door. That captures so many aspects. When somebody walks into a service, they're met with a person who can help them find their way through, can guide their way through, and treat the whole person, listen to what that person needs rather than come at them with service guidelines that are not listening to the person. The next one is that the model needs to be tailored to individual service needs. And probably the key in the centre there is the collaboration between services, those relationships. And if you look at the uptake framework, there's steps in terms of taking that model into practice, and we've developed some guidelines around that and some really pragmatic steps to help people through. But this is the simplified version. First, identifying who we need to work with, who are the key people, and how we're going to know how we're going and what we've achieved is number 2. Number 3 is the key, developing those relationships, identifying where you're heading, where's the connection, and taking the time to do that and giving people, time to go and work in different sites, shadow, peer mentor, really get an understanding of what the other clinicians and the other consumers are working through. Through that process, that began with a little project on the north coast of New South Wales, developed into a PhD, and then it we had some people interested from other areas, and we started to explore how those connections could be developed. And there was interest from the UK, and there was also interest from America. So we had some visits from people from Boston University and a number of different associations. They came over and talked with us about our model and how it might work in America. And then we were very fortunate that I was able to take a 2 or 3 month placement supported by NDARC in the UK, where I travelled around and met with sites, met with services, met with researchers, and actually spent some time having a look at how things are done in other countries and what the challenges were. In terms of key similarities and differences, America was probably quite different to Australia in terms of a lot of their work is done within one service. So the mental health service need their workers to be skilled up and working on drug and alcohol as well. But they still needed to build those relationships with other services, because there was obviously, a connection for people, because they might attend one service and they might attend another. If they don't have a mental health issue, they might just attend a drug and alcohol service. So those connections were different, but still really important. In Scotland and the UK, it was very similar to Australia, where there were lots of services operating in silos. So those relationships between the services were really key. From a consumer perspective, it was about giving genuine power to the people that are receiving care and having them, actively involved in what the care looks like. From a service perspective, maximising opportunities, drawing on the existing resources. When is it the right time? In Scotland, for example, it was really a high-profile time. There were a high number of deaths related to substance use, and people were mobilised. So it was a terrific time to get over there and talk to them. From a research perspective, it's about connection again, getting a seat at the table and being able to adapt to clinical settings. So to finish this off, I guess the key learnings from this, integrated care is a long game. developing relationships, making change happen in practice takes time, and it takes, you know, continued effort. It's not something you can just put in place and walk away from. Our model was received incredibly well in Scotland, and over that period, I ran 3 seminars, something like 4 forums, and over 35 meetings. And we were planning to be there for a month, and I stayed an extra month because the you know, people were so interested, so we stayed. And we said to them, why are you interested in this little model that we developed on the north coast of New South Wales? And they said, because it happened in real time. It's while you were working with people, the staff continued to work with people, and the consumers were involved. So our take home from that was, from little things, big things go. You don't need to try and affect change across an entire system. You can start with a little system and build from there. And I guess the next steps for us around this, the future is building the model around the people. So expanding this little framework, asking what they need to facilitate change across multiple settings, adapting our framework into a tool that multiple services can use to identify what they need, using their existing tools. Services don't routinely and efficiently apply best evidence practice, and one of the primary reasons is that there is an over-reliance on models of research translation at the moment, and sometimes those models really work. However, existing services have no capacity to systemically and continually evaluate the impact of those service changes or policy initiatives in real time, which means that the opportunity to learn about who does and does not obtain a meaningful benefit is almost always lost. So the final note to leave you with is that every system delivers exactly what it is designed to deliver. We can't just implement models and frameworks. People need to know how to do it. And that requires listening to the voices of the people that are affected the most by the treatments that we're developing. Thank you so much for your time.
Terrific, thank you, Kath. Very interesting as always. So our final presenter this afternoon is Andrew Amor, and we're very excited and privileged to have Andrew make the time to speak to us this afternoon. So he runs, he's the CEO of a service called Milia Rumara, which is based in Broome, but provides alcohol and other drug programs and services throughout the Kimberley region. Andrew has been working for a long time in the drug and alcohol sector, and he's going to be talking about, you know, from a real service provider and service leadership point of view, what research means to him and how he's developed partnerships. So Andrew, if you're good to go, I'll hand over to you.
Thanks, Anthony.
Andrew is using satellite, so it might be a slight delay.
Okay. How's that, Anthony? I'm on.
Yep, perfect. Go for it.
Okay. Now, like you said, Anthony, I am via satellite. Unfortunately, we're in a remote area and we can't access ADSL2. I did get when Catherine was speaking, I did get a couple of messages saying I've got an unstable connection, but I will push through anyway.
I think, yeah, great. I was going to say, I think we couldn't see your screen, but we can now. Thanks, Andrew. Go for it.
Yeah, it's a bit quiet. All right. First of all, I'd like to pay my respects to the land I'm presenting on, which is the Yaru land. And like Anthony said, from the Broome area, I'm actually a Gidja man from the East Kimberley, and you might have in the media recently might have heard about the Argyle diamond mine closing down, and so that's on Gidja country. I also would like to pay my respects to all the other Aboriginal and Torres Strait Islander people participating in this webinar. My talk today is looking at a life course approach and response. And the first slide is just a to give people some idea, if you haven't been here, what the country looks like. This is on Ardie, this is Ardie Loon on the Bard country. Of course, we're saltwater people. A bit about Millie. We're established in 1978. We have a family-based model of care, and that means that kids come to us as well. We're an ACHO, and we have a 22-bed residential program. Our minimum stay is 13 weeks in that residential program, but people can stay longer depending on circumstances. And we also have attached to the residential program a 39-week region-wide continuing care program. Plus we have transitional housing as part of that. There are two residential services in the Kimberley, one in Wyndham called Now Hour, and so we have a team based once they leave rehab. So the whole idea is to have 52 weeks of intervention, where it starts with a high intensity short-term in rehab and then slowly transitions to moderate intensity, medium term, low intensity, and then to X density, where we hope that we get to the stage where people can manage their own recovery. This is a photo of some of the people that were involved, clients and staff, in one of the Shinji Matsuri Festival. That's an annual festival held at Broome, and this was in response to the increase in ice within the region, and the idea was raising awareness about ice, particularly amongst the remote communities. A life course approach is not a new concept. Back in 1667, quote from an English poet, John Milton's Paradise Lost. Lost, of course, is famous for a lot of quotes. Childhood chose the man as the morning chose the day. 1941, Sioko, while studying school, the children in Maryland made the comment that adulthood is often brought about the cumulative effects of a long period of time, many pathological conditions, many incidents, some which take place and are perceived in infancy, and also, of course, there's the recent time, that was his one was the fetal origins of adult disease, where his hypothesis holds that events during early development have a profound impact on one's risk for development of future adult disease. So this is something that's not new. Life course approach extends across multiple life stages. It's about how early life experiences can influence health outcomes across a lifetime and potentially across generations, recognises the importance of timing, dose and duration, and the links between exposures and outcomes. And we look at it from two different perspectives or phases. There's a growing phase that we do, and a reproductive, and including a parenting phase. This is just to give some idea of the types of areas that we look at. Preconception, big issue for us in the Kimberley is unplanned pregnancy. I think we're about 70% as opposed to the national average of 50. Prenatal period, and of course we won't go too much into that, but the very critical period. Postnatal period as well, early childhood, middle childhood, and right through to old age of the elderly. For a cohort of the population, substance misuse is a chronic, with other chronic diseases like type 2 diabetes, chronic heart disease, coronary heart disease, and cancers, where exposure and development of disease and clinical recognition suggests that there are life exposures followed by clinical manifestations later in life, and this is going on what the Barker hypothesis was stating. So then what are the similarities with substance misuse? Are there things going wrong in life that may predispose an individual to dependence and addiction? If so, where should we be focusing our efforts? I've just put this slide up just to give some idea about when people come into treatment, what are some of the issues that we have to deal with. And I know some of you are familiar with all of this. On the left, which is positive outcomes, which is at one extreme, and on the right is negative outcomes, which I'll talk a little bit about, but there's a whole lot of different areas in between which I haven't included. The sad part about it is when I was putting in the negative outcomes, I ran out of space on the slide, and there are some key areas that I didn't get to put in here, such as self-harm and suicide, child protection and legal issues. But you can see as when someone comes into treatment that we see, there are a whole range of things that we have to deal with, and they come to us with all these layers of trauma. And this is making it difficult for us to manage, not only while they're captive in rehab, but also when they return to their normal environment. A big one, of course, here, as you can see, as I go down, there's toxic stress exposure, which is common, particularly from kids, low birth weights, poor social determinants, which we all are aware of, and disconnection from culture, land and community, particularly amongst our younger generations. So why are we seeing poor recovery outcomes? Like I said, there's layers of trauma leading to allostatic load. That is the wear and tear upon our bodies and brains that we see over a long period of time. And this is affecting both how we view the world, but also our physical health. And the negative effect and dysphoria that leads to negative reinforcement. People go back to drinking and drug taking because of that. People we see are in crisis when they come to us. There are a whole range of issues going on. And the interventions that we provide cannot address the multiple issues that individuals have during the time of treatment. So we're only able to deal with those issues that are important for those clients, and that will actually be meaningful for that client once they leave rehab. So what's our approach? So early intervention is the key. It goes without saying. So we're looking to reduce risk factors and enhance protective factors. It's a simple public health approach. And importantly, during the critical and sensitive periods of development. But there's also opportunities where our brains may be more plastic and open to positive experiences and influences. Reduced exposure to stress. I think this is something that we, in the AOD sector, we should have our heads all around. Stress is a significant part of why people are using alcohol and drugs. And as I talked about in negative affect, I mean, negative affect and alcohol are closely linked, and drug use as well, closely linked, and we need to no doubt view them as two coexisting things. And we need to provide stable and supportive environments where pregnant women and families can thrive. So what are we looking at more of? I must say that over many years with having families come to our rehab, we focused primarily on the adults, the mum and dads, and we weren't doing enough with the children. And we are seeing that children are coming to us with issues of their own, their traumas, their adverse childhood experiences. And so over the years, we've realised that we have to change our model of care. And while we've got families and children in rehab, they're not transient around the region, we can do some good work with them. So primary care, AMSs and GP services, of course, maternal and child health services, obstetricians, paediatricians, education providers, and child protection. A snapshot of our previous year. So we also allow pregnant women, so pregnant women can access our program. We had 7, 3 giving birth and returning to rehab for a period of time, and 17 families with 36 children. And all school-age children engage with school, So in summary, preventing relapse is the focus, of course, for all of us. That's where we'll make the biggest difference and change. We need to screen for negative affect across the recovery journey, not just in rehab, but also when people return and particularly when they're part of our continuing care program. And intervene early when a lapse does occur. We need to identify and intervene. So keeping in contact with people across the region is important. A life course approach to alcohol and other drugs and mental well-being is identifying the risks during key areas of development, which I talked a bit about before in one of the previous slides. And we also need to enhance protective factors. We need to ensure that kids have stable and responsive environments where there can be good nurturing going on, nurturing and learning, and a well-regulated response system. So we want to make sure that that kids do not have too many stressful situations, which may lead to that. We've talked about allostatic load, which has profound effect later on in life. Safe and supportive environments, allowing children to be children without fear. So plenty of open play spaces. And of course, they need to eat properly, so good nutrition, not just prenatally, but also postnatally. And we know that we talk about the first 1,000 days of life and that they are critical, or the first 3 years of life are critical for brain development and also other systems within the body to continue developing. So it's important that we make sure that we manage that when we can, and we provide the right interventions. So just towards the end, we need to grow strong, healthy kids. This is good for the preservation of culture and passing of cultural knowledge to future generations. And it's good for society in general, as people can value add more to society and engage in the economy. It's also important to acknowledge that a lot of cultural knowledge is passed on orally, so we need kids to have their brains in good working order, and so that they can retain the cultural information and pass it on when they become elders. So that's the end of my presentation.
Brilliant, thank you. Yeah, thanks, Andrew. That was terrific. And I might just get you to keep your microphone and camera on, and maybe perhaps invite everybody else to as well, all the other presenters, if you wouldn't mind. Thanks. There's lots of people, I know we're right on time, and there's lots of people still engaged though. So we might just have a few minutes of Q&A if that's all right. So there's a couple of questions here. So one, a comment really from Suzanne's story, Andrew, just saying that she really liked your life stages. And I was thinking the same thing. We tend to focus or overemphasize the sort of acute, immediate problems associated with drug and alcohol harms often. And we tend not to think so much about the kind of antecedents and how people's lives have, evolved to that point. So I thought that was really interesting as well. Thanks. There's a question here from Maggie Brady, who needs no introduction, for Michelle. And she says that Michelle spoke about the unintended consequences of AMPs and observed that people in those Cape York communities wanted greater access to data to help them have an informed input into future strategies. Often people forget what things were like in earlier years. Often it was much worse, with higher rates of illness, alcohol-related illness and injury. Has your team, Michelle, thought of getting access to earlier data, for example, during the canteen and pre-AMP years, and making those data available to remind community members why the restrictions and limits were introduced in the first place?
Yeah, thank you, Maggie, for the really important question. I'm just wondering if I can share my screen as a way to respond to the question. So one thing that because the project was so large, I didn't touch on any of the quantitative findings. But this slide comes from one of our papers, and you can see there it's based on Queensland Police data and also RFDS data. And so Maggie's right that there was a significant decline in violence rates. This comes from 4 communities. So it's not all of the communities, but 4 communities. And you can see there's a sharp decline in injury or violence related injuries. At 2002, which is when the first wave of AMPs were introduced, and then again it continues to decline in 2008. You can see there's a sharp increase in 2012, and as I was talking about before, our project, we were doing the interviews in 2013 and 2015. So this is the period that we were in the community. So the sentiment, particularly around leadership, really was about not going back to the term that was used, the bad old days, but I guess about, you know, giving communities greater access to data to inform local responses, particularly to the sly grog trade, so that this trend after 2012 doesn't continue.
Is there any, Michelle, is there any sort of evidence that you've uncovered or about whether communities that choose AMPs, and they're very driven by the community, you know, as opposed to having them imposed by some sort of legislation or regulation, is there any evidence that they work better?
Look, I'm not across that literature actually of late, Anthony. We felt that there wasn't necessarily ownership in the Queensland communities of the legislation because they had a real lack of empowerment to be able to make changes. And as we were talking about earlier, that criminalisation and sly grog trade have become so entrenched. And the review period for the by the Queensland government had run for 7 years with very little change to the policy. So, but I'm not familiar with the other context.
All right, and there's a question for Andrew. Andrew, being, you know, given the sort of remoteness of Broome, do you have to sort of shape your programs to, you know, allow for, you know, the access you've got to health professionals, or, you know, the travel that people might have to do to access the service? Are there things in remote areas that you have to do differently?
Yeah, good question. And as you know, the Kimberley is a large part of Australia, and you can travel up to 2 hours before you get to another community or town, and so the access to services is a problem. However, during the beginning of the COVID pandemic, we too had to change our way of working and making contact with people. And so looking at video conferencing, which is what we're doing now, is also an area that we look to improve with to access our clients once they were locked down in the communities. This is also true for accessing specialist care. So we are now exploring where there isn't an appropriate provider within Broome, for instance, or the region, that we can access through video conferencing. I won't say telehealth, but video conferencing from anywhere around Australia. So as long as if there's a appropriate provider and who is willing to do that, we're prepared to pay for it. A good example is CBT for insomnia. There's not many providers here that would be able to do that for our clients, and it is such a common issue for clients in rehab or clients in general with AOD issues. So yeah, using VC is definitely a way to the future for us.
Great. And just in part, we'll just go to one more question. And on our way there, Maggie just put a message up, Michelle, saying thanks for your answer. So Michael, one for you. Do you think people in prisons would favour or welcome the opportunity to be involved in, you know, alcohol and cannabis program? You know, you sort of mentioned that both of those were seem to be reasonably prevalent. Do you think there's an appetite, you know, from prisoners to be engaged in programs? Yeah,
look, that's a very good question. The peer education model is something that came out a bit in the PhD, as you'd remember, Anthony, and published a paper earlier this year that sort of talks a little bit about that. But I think some of the fellas inside prison would probably be very interested in taking on that role. It's about how do you then sort of operationalise that kind of a program where you've got peer educators, and maybe what would be ideal and would be to have sort of a co-facilitation model where you've got your sort of person delivering the program that has that sort of training to do so, delivering that with perhaps an inmate who's happy to be a peer educator. So I don't know how much of that is happening in terms of drug and alcohol programs in Australian prisons, but there's certainly a lot of peer education around buddy systems when people come into prison, and to be orientated and that sort of thing. Yeah, but it'd be good if there was more.
And picking up on Kath's work, on integrating services better, it'd be really nice if we could get, a more of a system level model where whatever happens in prisons, people can get, access into services like Andrew's that are back in the community. So they're not just kind of, going from one thing without any support along the way.
Absolutely. I mean, different jurisdictions are at different stages, so I'm not sure quite what's happening in WA, Andrew. I know there was quite a effort to try and get that happening in a more streamlined way, but it's sort of a sort of thing that you need to have continuous effort to do. So it's not like you set it up and then it's fine and it'll keep running. It requires a certain level of effort that's renewed each time to make sure those partnerships, relationships are all working to get that kind of a process happening where people can have a streamlined sort of going from prison to the community. But the other thing with that is that sometimes some of the guys I spoke to felt it was like being sent to a different type of prison almost, because they wanted to spend a bit of time with their girlfriend or stuff like that. And so there's a real frustration in the way that happened as well. So a bit of work around that perhaps.
Yeah. It's, as you said in your talk, Michael, they're not, none of this is easy, but it'd be really nice if we could do some work around how to, as we say, work across the whole system of care and link up so that clients get access to the care they need it when they need it, at the most sort of efficiently, in the most efficient way.
Absolutely.
All right, well, we might leave it there. So, hang on, there's one more before you all escape. Go and have a cup of tea. Hang on. Another one from Suzanne Story saying they're trialling programs in New Zealand where people something out of prison into a unit next to prison grounds. Okay, so the people then go into the community and work and return to the unit. This allows an earlier move out of the actual prison. So those sort of transition programs, Michael, do they happen in Australia?
Yes, they do. How widely? They're available. I'm not sure. I do know a little bit about the ones they do in South Australia, strangely enough, and they do seem to have a good effect where people sort of the old term would be a halfway house, and which is a really sort of old, outdated term, but that's pretty much what it is. And those sorts of programs can work because accommodation can be a huge challenge. So people go back to the same situation and there's dysfunction and chaos all around them, and it's people who they'd been drinking and drugging with, and with all of that happening, it's pretty easy to relapse. So that kind of supported accommodation is really important.
Yeah. All right, terrific. Well, we'll leave it there. So thank you, everybody, for attending and listening in this afternoon, but particularly thanks to all the people who presented. Andrew, really appreciate you making the time to call in, so thank you. But to all of our presenters, thanks very much. It was a real, very thought-provoking and a real treat to have you all presenting at the one time. So thanks very much. Remember, you can go onto the website and vote for your favourite poster. Remember to register for the next 2 Thursdays for our next 2 sessions. And also, if there's a burning question that you want to leave, you can also go into the networking part on NDARC's annual symposium website and leave a message there, and we'll get back to you with an answer. And finally, the recording of this session will be sent to everyone who was registered. So, okay, so thank you all very much again, and hopefully we'll see you all next Thursday. Okay, good afternoon.